Thanks, Chair. It is really my great pleasure to be invited to have a talk this afternoon. I started my academic career on screening of cervical cancer almost 40 years ago in China when I was studying medicine in the Shanghai Medical University, now a part of the Fudan University, Shanghai. So a few years ago, I was actually asked by the Gates Foundation to look at the national immunization program. HPV vaccine is one of the priorities. So I back to the cervical cancer HPV vaccination again. So so today I want to talk about implementation strategies, policies, practice for HPV vaccination in Asia Pacific regions. So what I want to talk today is the disease burden of cervical cancer and the global strategy for HPV vaccinations, and also current HPV vaccine introduction and implementation in the region, and then talk about a little bit key challenges and recommendations. So in terms of global cervical cancer burden, cervical cancer is the third common cancer among women globally. And based on the WHO estimation, in 2022, about 662,000 cases detected. In Southeast Asia, 70,000 cases. Most of cases in Latin America and Southeast Asia. So Africa, Latin America, and Asia are the high burden regions. About, cervical cancer also the third leading causes of cancer-related deaths among the women. And again, in 2022, about 350,000 deaths globally, and also more than about 15% in the Southeast Asia. So this shows the incidence per 100,000 populations in different regions. Latin American, Caribbean region consistently show the highest burden in both incidence and mortality, followed by the ASEAN countries. And the global trend indicate variation across different regions, with some regions experience increased trend as shown, and others, some is stabilized. This, Pacific Island, Fiji, Papua New Guinea, Solomon Island, they are got the highest actually incidence rates and also mortality rates of cervical cancers. Indonesia, Maldives, Myanmar also in the high actually burden categories of the countries. In comparison with high-income countries, Australia, New Zealand in this region. So what is the global strategies on HPV vaccinations? And first, I want to cover HPV vaccine. Human papillomavirus, HPV, is a common virus with more than 100 types of subtypes and related to cervical cancer and throat cancers. So luckily, we have HPV vaccines which are designed to prevent infections with the most dangerous strains, particularly type 16th and 18th. These two types together responsible for about 70 of cervical cancer cases globally. WHO has developed a global strategy, and this strategy is aimed to eliminate cervical cancer by 2030. And the vision is a world where cervical cancer is eliminated as a public health problem. And in this global strategy, it suggested 90% of girls fully vaccinated with HPV vaccine by age 15 years. 17% of women screened with high-performance test by 35 years of age, and again before the 45 years old. 90% of women identified with cervical cancer should receive a treatment. So these are 3 targets proposed in the global strategy for elimination of cervical cancer. So primary targets, girls aged 9 to 15, and 2 doses schedule for all the ages. There are options, 1 dose schedules for 9 to 20 years old. If those people, this morning we talk about people living HIV infections, so if these people infected HIV/AIDS, and 2 doses or ideally 3 doses. Second target is boys and older women. Introduce vaccination of the boys and older women should be carefully managed if affordable, feasible. So these are WHO suggested. I will skip this. So current HPV vaccine introduction and implementation in regions. United Nations has more than 190 member states, of which 142 accounted for over 70% of countries, which have already introduced the HPV vaccine into their EPI, expanded program of immunization, or called the national immunization programs. But unfortunately, over 52 countries have not yet introduced HPV vaccine as a part of their EPI or national immunization programs. So this is the figures in the chart show the global HPV vaccine coverage. First dose or 2 doses. For the girls, the coverage around just about the 20%. For the first dose, and for those 2 doses is 15%. For boys, most occurred in the Western countries, Australia, England, the United States, about 5 to 6%. So as I said, the majority of countries have introduced or included the HPV vaccine into their national immunization programs, but some countries still have not. Here, we divide into Gavi and non-Gavi. Gavi is the Global Alliance for Vaccine and Immunization. If the country is in the category of low-income country, and Gavi usually give them money, fundings, and also help them to procure vaccines. But if the country has transitioned from the low-income country to high-income country, then they are no longer eligible for international fundings, Gavi's funding. So some of countries like Vietnam, Mongolia, they are in the transition. So recently, we got a research grant from Gates Foundation, working with the Health Strategy and Policy Institute in Hanoi, Vietnam, to develop strategies, policy options for HPV or PCV vaccinations, because Vietnam, as we all know, Vietnam's economy has grown very quickly, and they will be no longer eligible for funding from Gavi by end of 2025. So these are the countries in Asia facing the challenges. So HPV vaccine delivery have different strategies. Most countries in the region have selected schools as the primary vaccine sites. But the strategy may also shift over time, have varies within the countries. Health facilities, routine community outreach services also serve as secondary sites for out of schoolgirls or schoolgirls who missed those at schools. So most countries begin introduction with single age or school grade cohort girls aged between 9 years old to 11. Philippines, for example, provide a vaccine to catch-up group of older girls up to age 13 or 15, 18. Laos conduct multi-age cohort vaccinations over the last couple of years. Reaching critical population is so important. In many lower and middle-income countries, out-of-school school remains a large untouched adolescent population for HPV vaccine. So for community or facility-based strategy or where out-of-school girls are a significant part of the population, age-based eligibility is usually preferable. Challenges, there are many challenges increasing coverage of HPV, but given the time limitation, I want to just talk the three major challenges. First is introducing a sustained HPV vaccination into national immunization programs. So many countries in the region, such as China, Mongolia, Papua New Guinea, Vietnam, have not yet introduced the HPV vaccine into their national immunization programs. Also, some of these countries have provided free HPV vaccination at some areas, particularly most developed region, with the support of their local government. For example, in Vietnam, Ho Chi Minh City, I met the official from Department of Health of Ho Chi Minh City, and they said that our coverage is over 90%. And China has 34 or 33 provinces level, of which about 9 to 10 provinces, particularly in the East Coast where economics good, they already provide a free HPV vaccinations for the schoolgirls. But at the national level, these countries have not yet introduced the HPV vaccine to all the eligible girls. Also, those countries in a transition from Gavi, as I said, the Global Alliance for Vaccine and Immunization supported to non-Gavi support HPV. Cambodia has now got lots of money and with lots of support of vaccine, HPV vaccine and other vaccines procurement from Gavi UNICEF. But after, in probably 2 or 3 years, Cambodia is no longer eligible for Gavi support. But I'm not sure whether or not the government of Cambodia will be ready to step in to provide all the fundings to continue the HPV vaccinations country-wide. And also whether or not these country government, this national government, have capacity to negotiate a price with international manufacturers. So these are all the challenges facing in many countries in the region. Second is it's difficult increasing high and equitable coverage. You all probably know it's not difficult to understand. Insufficient outreach visits, strategy for out-of-school girls are scarce, outreach visits of out-of-school are insufficient in these areas. Sometimes confusing about the eligibility, which age, or which grade, right? So, and also burdensome consent requirement because they are not adults, they are teenagers. So if you want to give them HPV vaccination, you got to get a consent from their parents, their guardians, others. So that's other things. Another is insufficient supply of HPV vaccines. Due to the vaccine supply constraints, many countries in the region whose national immunization program has included HPV vaccine choose a single age cohort for vaccinations, such as Thailand, Myanmar, Malaysia, Brunei. Also, many manufacturers produce the HPV vaccine, and they got to get a pre-qualification from WHO, and also they have got to in the list of UNICEF in eligibility of providing HPV vaccines. So supply constraints might be eased in the near future, so based on the estimation, maybe by 2025 or 2026, supply of HPV vaccine may be better. So recommendations. WHO has updated guidelines, so implementing one-dose vaccine schedules where is possible, where is appropriate. So I think the Merckers, others wants to keep these 2 or 3 doses in order to make more money. But the country government or national government should look at their evidence, scientific available, if possible, and reduce the reduction of the doses. If you only use one, you could reduce cost of vaccine, and also reduce the complexity of multiple visits due to the multiple doses, and also could actually alleviate vaccine shortages and achieve high coverages. Second is to develop a sustainable finance mechanism for HPV vaccinations. International organizations such as Gavi, World Bank, UNICEF should enhance their support strategy for middle-income countries to prevent the backslidings. As we all know, middle-income countries have the largest proportion of people living in poverty. And many people in middle-income countries, India, China, Indonesia, Pakistan, they actually have a big chunk of poor peoples. So if these international organizations withdraw their support, then the poor is suffering. So gladly, I'm delighted to learn that Gavi is revisiting their strategies, particularly linked to the middle-income country approaches. And also, national governments should prioritize their support to the poor regions, vulnerable groups of their country to optimize immunization coverage and improve the equity in HPV vaccinations. We also should consider other innovative approaches, social innovations in financing of HPVs. Pay it forward is one of them, and many of you know that, and some of you have done this kind of research, which is really helpful and meaningful. And finally, is enhance the health education and through effective communications because of many concerns, safety issues, side effects, vaccine hesitancies. So health education materials should address concerns about safety, side effect, efficacy, importance, and the cost of vaccinations. And also we need to educate the health service providers. And they should provide proactive rules in educating patients or their parents about HPV and cervical cancers. And also we need to develop a customer tailored interventions. So I stop here. Thank you very much for your attention.
Yeah.